Hello. Today we are going to talk about Chapter 19, Cardiovascular System. We're going to start the cardiovascular system talking about blood. So the entire Chapter 19 is about blood, the different parts of blood, and what our blood does for us. Our blood is made of three different parts. We have the plasma. That plasma is the clear to kind of yellow, maybe straw colored part. This plasma is technically the liquid portion of our blood. We have a buffy coat that says it's our white blood cells and platelets. Then we have our red blood cells at the bottom. If you were to put blood into a test tube, if you let it sit for long enough, the blood will separate itself out just like this. The red blood cells will be on the bottom, the white blood cells, platelets will be in the middle, and then the plasma will be at the top. Those going into nursing will learn a centrifuge tends to be used on blood because a centrifuge will separate out these three different components of blood very quickly for us. And that way some blood tests require just using the plasma. Other blood tests require looking at red blood cells only or the white blood cells. So this way we're able to access this specific part of the blood that we're trying to test. So the different functions and properties of blood, as we just looked at, it has three main parts to it. Technically, the red blood cells, the white blood cells, and the platelets are known as formed elements. These formed elements are what float in that plasma. Our plasma is that liquid portion, so it's got to have water in it of some sort. But we also have different proteins that fit into this plasma. These proteins is what we will talk about, have specific roles. They do specific things. And then there's other solutes. There's lots of other solutes. There's wastes products usually in there, which is why blood is going to transport things around. It takes oxygen to our cells because we need oxygen to make energy. We get carbon dioxide from the cells and take that back to the lungs for every time we breathe out. We carry lots of different nutrients in our blood. Anytime we have a meal, any of the nutrients from the food that we eat is absorbed into the bloodstream from our intestines and then taken to certain places in the body to be stored or directly to be used. Blood can also help heat parts of our body. And then we also have waste products. Waste products in our blood gets transported to the kidneys where they will get filtered out. When we get to the urinary system, we'll go into detail about how that works. The blood is going to regulate your body's homeostasis. Homeostasis is that balance your body maintains. We have to maintain a certain fluid level in our body. We use blood for regulating the blood's pH, which stays in a very narrow range, usually between 7.35 and 7.45. We adjust our body's temperature. So when we get too warm, blood vessels dilate. They get larger, closer to the skin's surface to help release out heat. If it's cold, the blood vessels closer to the surface constrict and close off to keep the blood more towards your core to keep your vital organs functioning. Blood is also going to regulate the water contents of cells. If our cells need more water, they pull it out from the blood. If the cells have too much water, As water travels through osmosis, it's going to travel into the blood. Osmosis, again, is where water travels from an area of high concentration of solutes to an area of low concentration of solutes. So water is moving from one place to another to kind of even out the amount of solutes in that area. Your blood protects you. It's another main function. As our blood, if we get a cut, we cut a blood vessel, it's going to clot. Those platelets are going to come in and form a clot to help prevent the loss of too much blood. Your white blood cells, they're what help to keep you healthy when some sort of microbe, bacteria, virus, fungi invades your system. The white blood cells come along and they're going to fight against these different pathogens that may have gotten into our system. So our body weight, 8% of our body weight comes from our blood. A normal, well, depends on how large you are, but the average person usually has about 5 liters of blood. So 8% of that is just their body weight is coming from that blood, that 5 liters. We have more plasma than we have those formed elements, those red blood cells, those white blood cells, and those platelets. That plasma has proteins, water, and other solutes, as we looked at on the slide before. But if we start looking at what some of these proteins are, we have albumin, globulin, fibrogen, and then there's other ones that are found in there, but they're in very small amounts. We have that water, and then we have other solutes. So we carry electrolytes. We carry nutrients. So we went over gases, that's that carbon dioxide and oxygen. Waste products, and then regulatory substances. These are all found within our blood. Some of those regulatory substances would be hormones. As we talked about in the first chapter, hormones travel through the blood to get to their specific target cells. So our formed elements, platelets, white blood cells, and red blood cells. We have millions upon millions of red blood cells because we usually have 4.8 to 5.4 million red blood cells per microliter. That's a lot. And then our white blood cells get distributed out even further because we have 5 different types of white blood cells. We have neutrophils, lymphocytes, monocytes, eosinophils, and basophils. We'll go through all of those different white blood cells and what they do for our system when we get to the white blood cells section. So on the left here, we have an electron micrograph showing us what a red blood cell looks like. A red blood cell kind of has this biconcave, so both sides come in. They have this kind of biconcave appearance. White blood cells versus the platelets in purple. If we look on the right, we have a blood smear. This is what we see when we look at blood under a microscope, which we will do in lab. We will look at blood smears, not our own. We have pre-made smears of blood. We can see all the red blood cells, the white blood cells. There's 4 different white blood cells in here, and then all these little purple things in here again. Those are all platelets. These are all the different parts of our blood. So here's some of what is found in this blood plasma. As I said, we've got a lot of different proteins, other solutes, so albumins, globulins, and fibrinogen. These all help with different roles. Like albumins, They're going to help maintain that osmotic pressure. So making sure that blood has enough fluid in it that matches what is happening outside of the blood vessels. Globulins, they kind of help attack viruses and bacteria. Fibrinogen, they help with blood clotting. Then those electrolytes are any positive or negatively charged ions. So there's lots of different electrolytes we're going to find. Nutrients. So you just had some protein with a meal, you're going to have some amino acids in your blood. Glucose. We have to maintain a specific blood glucose level. Fatty acids, cholesterol, vitamins, minerals, these are all being absorbed from any foods that we eat. Oxygen, carbon dioxide are the two main gases found, but we do also have small amounts of nitrogen in our blood even. And then those regulatory substances, I mentioned hormones, enzymes, vitamins. And then we have different waste products. We'll go through some of these waste products as we get through this blood chapter here. So that blood plasma, I mentioned it was a straw-colored liquid. Once you let either a test tube of blood settle or you spin it in a centrifuge, that blood plasma is always going to be at the top. Those red blood cells, the other name for red blood cells is erythrocytes. Red blood cells are more the common name for them. They're more called erythrocytes when we're talking about red blood cells more in the medical community. Their main job is to transport oxygen. So they pick up oxygen from the lungs and take it out to the different tissues. They also pick up carbon dioxide from those tissues and take it back to the lungs. Those white blood cells are the common name for leukocytes. And they're going to protect you from any pathogens that make it into your system to help prevent you from getting sick. Those platelets, they're fragments of a cell. We'll look at how platelets are actually formed. We also have hematocrit. Whenever you get a blood test done, one of the different blood tests they do is to look at your red blood cells. So when they're checking for your hematocrit, they're looking at that percentage of your total blood that is red blood cells. Should be about 45%. It usually varies from person to person, but that's usually around average. And polycythemia, someone who has polycythemia has too many red blood cells. The more red blood cells you have, the increased chance of having a stroke. We'll look at how that works in this chapter as well. So as I mentioned, blood tests. There's a lot of different blood tests. Blood tests can give us an idea of what is happening inside the body. These are the easier, the least invasive types of tests that can be done to find out what's happening on the inside. So we can look at how organs are functioning just by a blood test. Again, we diagnose different diseases. We looked at some of those. A lot of endocrine disorders are diagnosed through blood tests. Diabetes, heart disease. We can find out how well medications are working, if medications are effective or not. There's a lot of new studies and blood tests out recently that you can actually, through a blood test, find out which type of medication works with your blood type and your immune system versus something else. It's kind of cool. So one of the main blood tests, the one that I mentioned on the slide before, is a complete blood count, or as we call it, a CBC, because it tells us how many red blood cells we have. It tells us the size of those red blood cells. Yes, the size of the red blood cells can actually indicate a disease if they're too big or too small. Hemoglobin, how much oxygen? Hematocrit, that was that percentage of the blood that's red blood cells. We can even find out how many and that percentage of white blood cells. We also look at how many platelets somebody has. The next most common blood test that people have is what is called a basic metabolic panel. This metabolic panel, we're checking blood sugar. We're checking different electrolytes in the blood. We're checking the calcium levels of the blood. Blood urea nitrogen, that can tell us how those kidneys are functioning. That creatinine, there we go. That's also tested in this basic metabolic panel. There's a lot of things that we can get from running a basic metabolic panel. Checking that glucose, this is one of the first steps in checking people for diabetes. If their blood glucose level is too high, then we can start looking at other blood tests that get more specific with glucose. But usually if we're using insurance, a lot of times you have to prove to insurance companies why you're running certain tests. So showing insurance companies their blood glucose is high, so we need to start running some of these other tests to help diagnose if something is happening. We can look at enzyme tests. There's lots of enzymes that are found in those form elements in our blood. And this is mainly for organ damage. A lipoprotein panel. We're looking at our lipid levels, our cholesterol levels, those high density and low density lipoproteins. Those are going to tell us our risk of heart disease. So there's a lot of different things that we can learn from these different blood tests. These are just a small sampling. There's hundreds of blood tests that can be run. This is just a small sampling of what we can get. So our lymphocytes, those white blood cells, those white blood cells, they're part of those formed elements. Those white blood cells have the longest lifespan because they can live for years. If they're being used to fight off some sort of microbe or pathogen that got into your system, that's when they may live for hours, days, or weeks. They may die off pretty quickly as they are trying to fight off different diseases, different bacteria or viruses that have invaded your system. Red blood cells and platelets. They're going to stay pretty steady depending on what is happening in your system. That number usually does not change very much unless there's some sort of disease happening. White blood cells, they're going to vary in number depending again on what is invading your system. You have some sort of virus that has gotten into your system. We're going to increase white blood cells to be able to fight off that virus. That is where a complete blood count can be very helpful. Because when we get to the different kinds of white blood cells, specific types, we have a specific white blood cell that goes for bacterial infections. We have a specific white blood cell for viral infections. A complete blood count can actually tell us what type of infection is in somebody's system, give us an idea. So hemopoiesis is the process that our red bone marrow goes through to make blood cells. Our red bone marrow makes more than just red blood cells, it makes our white blood cells. It also makes our platelets. So that multipotent stem cell, this is what all of our different blood cells are going to come from. We start from this one cell, it's going to differentiate. It'll differentiate into myeloid or lymphoid stem cells. From there, they will differentiate to a pro-erythroblast that'll become a red blood cell and make a karyoblast. This is where platelets come in. And then we have all of our different types of white blood cells. We have an eosinophilic myeloblast for eosinophils, basophilic myeloblast for basophils, myeloblast for neutrophils, monoblast for monocytes that eventually become macrophages. And then we have T lymphocytes, B lymphocytes, and NK or natural killer lymphoblasts. Blasts build. They're the first step in making any of these blood cells. We also get a mast cell that comes from these myeloid stem cells. Mast cells release out different chemicals, as we'll get to when we get down to the white blood cell section. But all of our blood cells come from multipotent stem cells that come from either myeloid stem cells or lymphoid stem cells that are going to differentiate into their different types. Our red blood cells or erythrocytes, the most important part of these red blood cells is the hemoglobin. The hemoglobin is what oxygen is going to attach to inside of these red blood cells. And that's how we transport most of the oxygen in our blood. Hemoglobin, this is where iron comes into play. Hemoglobin contains iron. So each hemoglobin molecule, because of the iron, can hold on to 4 oxygens. So here's a hemoglobin molecule. We see this red blood cell. I had mentioned that it's this biconcave disc. There is no nucleus. A red blood cell, if I go back up, it starts with a nucleus. This pro-erythroblast here differentiates into reticulocyte. When it differentiates into this reticulocyte, we spit out that nucleus right at the end of the maturing of the red blood cell, because we don't need a nucleus in our red blood cells. So we get rid of it right before those red blood cells go out into that circulation. And since the nucleus is gone, that's what gives us this biconcave disc that is mentioned right here. So this hemoglobin is going to fit. We're going to have one over here, over here, over here, in this area. Each of these hemoglobins can hold on to 4 oxygens. So that's a lot of oxygen that each red blood cell is actually able to transport around the bloodstream. Here is a ruptured vein. Here is or venule. Venule is smaller than a vein. When we get to the blood vessel chapter, we'll go into exactly what all of these are, these different types of blood vessels, but you can see all of these red blood cells inside. You can see all these biconcave discs. They're trying to travel through this little venule, but this venule broke open. Something happened to it. So this is what we see. So hemoglobin does not only just carry oxygen. Hemoglobin does a lot of other things because it's going to help regulate that blood flow. So making sure the blood is traveling to all the areas of the body so all of our cells can have oxygen. It's going to maintain blood pressure. We need our blood pressure at a certain rate to help push that blood through the system. And it does that through the nitric oxide. We talked about nitric oxide in Anatomy 1 when we were talking about the nervous system. Here's another place in our body that uses nitric oxide. Nitric oxide is going to cause vasodilation. Vaso is for blood vessels and dilation gets larger. So when our blood vessels get larger, it allows more blood to travel through. It allows more oxygen to get to our cells. So this is one way that our blood pressure actually gets regulated through this hemoglobin. Like when you're exercising, a lot of your blood vessels dilate, they get larger to send more oxygen out to the rest, to your muscles and your tissues so you can continue to exercise. Red blood cells have carbonic anhydrase. Anything that has ACE at the end of it is telling us that it is some sort of enzyme. What carbonic anhydrase does is it takes the carbon dioxide that it picks up from cells. Cells are getting rid of any carbon dioxide that they create from that oxygen that they used. And it's going to take that carbon dioxide and it's going to convert it into water and carbonic acid. This is how we transport a lot of our carbon dioxide in the blood. We do this in the plasma, and that carbon dioxide stays in the plasma in the form of carbonic acid. So carbonic acid is an important compound found in our blood because when it gets back to the lungs, it's going to convert back to carbon dioxide for us to breathe it out. Our red blood cells, as I mentioned, our white blood cells live usually a lot longer than our red blood cells because our red blood cells only live for about 120 days. They get released out into circulation from the red bone marrow. They circulate through the system for about 120 days and they get worn out. They eventually die. When they die, our spleen and or our liver is going to remove those red blood cells, get rid of them. So new blood cells can be released out from that red bone marrow. When we're done with those red blood cells, our body likes to recycle things. If you talked about proteins in your Anatomy 1 class, we break down those proteins into amino acids and rebuild them up to different proteins. We do the same thing with red blood cells. We break those things down and we're going to recycle or reuse the different components again to make something else. So these different red blood cell life cycles. As our red blood cells get worn out, macrophages. These are one of our white blood cells. They phagocytize. Phagocytize means they eat or they engulf, wrap around and completely take inside of them those any kind of worn out red blood cells. The globin and the heme, they're broken down. These are different parts of the proteins. Proteins are just chains of amino acids. So they get broken down to those amino acids again. We use those amino acids to make different proteins, or we could even put them back together to make the same protein. We need something to do with that iron, because that iron, each hemoglobin had 4 irons attached to it. So we have to take that iron off of that hemoglobin. We take that iron and we put it onto a protein that is called transferrin. That transferrin floats and travels in the plasma. A lot of these proteins that travel in the plasma have something else attached to them, as we learned about in the last chapter, that endocrine system, because it makes it a lot easier for these different ions, hormones, chemicals to travel through the blood. So iron gets put on that transferrin and transported through the blood. Once this iron gets to its specific location, it breaks off of that transferrin, leaves the bloodstream, and it gets put onto a different protein called ferritin. Ferritin is our storage protein. We store iron in the form of ferritin. But what happens if we need that iron? Well, that iron's going to get released from that ferritin. It'll reattach to that transferrin, because that transferrin takes that iron to different areas in the body. That iron on that transferrin is going to go to the red bone marrow, as we're making more red blood cells in the red bone marrow, and it'll get attached back to that hemoglobin again to enter back out into the system. This is how we reuse the iron. We reuse the proteins that we just broke down. We try to reuse as much of anything that we break down in our body. We try to reuse as much as we can. So we just took our iron that we took off of a red blood cell. It was stored in that ferritin. It moved back to that transferrin to be taken to the red bone marrow. Now we're going through erythropoiesis. So we're making new red blood cells. As we're making new red blood cells, we need to take some of these other parts that we could not use. There are certain parts of red blood cells as they break down that we cannot use. Heme. Heme is something that sometimes we can use, sometimes we can't. But heme gets converted to biliverdin, which is green, or bilirubin, which is that yellowish orange. Bilirubin will go to the liver. Bilirubin gets released into the intestines through the liver. It passes into the bile. Bile is released from the liver, stored in the gallbladder, and released into our digestive tract whenever food enters the small intestine, where that liver releases it out. So that bilirubin is going to transport through the intestines. We have a lot of bacteria that live in our large intestine. Our bacteria helps us break down things that our own digestive system cannot. So in this case, our digestive system can't break down bilirubin, the bacteria does. It'll break it down into urobilinogen. We reabsorb some of that urobilinogen, there we go, back into the blood, which gets converted to urobilin, which is yellow pigment, and that's what makes our urine yellow. The urobilinogen that we do not reabsorb into the blood that gets cleaned out by the kidneys stays in that large intestine, gets converted to stercobilin. And that's what gives our feces that brown pigment. And this is where, if you don't have the correct bacteria in your large intestine, if things pass through that large intestine too fast, it can also give, because this biliverdin doesn't get broken down, it can give you more of a green type of feces because it doesn't get broken. These proteins or this pigment does not get broken down correctly, and it can change your feces to different colors. So this whole chart goes through everything, this picture that was on the last 2 slides. It goes step by step through where everything goes, starting from these red blood cells that are getting broken down. We get the heme and the globin, which that heme we take the iron off of, put it onto transferrin, and store it as ferritin. The biliverdin gets converted to bilirubin, goes to the liver, will be released out of the liver when the bile. So a lot of these, as these red blood cells get broken down, there's a lot of different places that this stuff goes. This bilirubin can get broken down to the stercobilin for your feces, or it can be converted to urobilin and gets released out in your urine. So it all just depends. But then that iron is going to go back to that red bone marrow and be reused as we make more new red blood cells. So different parts go different areas. Some of it we get rid of, some stuff we reuse. So what happens if our body has too much iron? It can happen. People who take iron supplements who don't need to be taking iron supplements can end up with an iron overload. We don't really have a good way to get rid of excess iron. That transferrin protein and those that takes iron around the body, and that ferritin that stores iron, they get all used up. There's none left. So we have a lot of iron left in our system. It can cause liver problems, heart problems, pancreatic problems, even gonad problems. Those female and male reproductive organs are the gonads. It can also turn your feces black, having too much iron in your blood. That is actually one of the signs that you have too much iron in your system, is having black feces. It can also cause those microbes that live in your intestines to flourish. Many more of them grow because they need a way to try to get rid of them. And it can actually have lethal effects because we need to keep a certain level of those bacteria in our system. If they start to grow out of control, it can cause a lot of different problems. So as we had mentioned, erythropoiesis is how those red blood cells get made. Mentioned it starts in the red bone marrow. It all starts from a hormone, erythropoietin. Erythropoietin is actually released by the kidneys, if you remember from the endocrine system last chapter. There's not enough oxygen in the blood is what stimulates the release of those red blood cells, or the creation of those new red blood cells, I should say. Reticulocytes are those immature red blood cells. They still have that nucleus. But by the end of those, as those reticulocytes mature, they get rid of that nucleus. They only take 1 to 2 days to mature, so it only takes them 1 to 2 days to finish growing and get rid of that nucleus. It happens very quickly. This video link here gives you a nice animation of how all of this actually occurs. So our homeostasis, our balance of our red blood cells, gets monitored and by our system, of course, and different hormones are going to be released out when we need new red blood cells, when certain levels are getting too low. So if we don't have enough oxygen in the blood, our kidneys will notice. Our kidneys will send out hormones to that erythropoietin to that red bone marrow. That red bone marrow is going to differentiate those stem cells to make red blood cells. Those red blood cells are going to be released out into circulation. More red blood cells means the more oxygen that we can carry. As long as we're carrying enough oxygen in our blood, our kidneys are happy. So this process happens because red blood cells are technically dying off every day. As they reach that 120-day mark, different red blood cells die off every day. So we're constantly making and secreting out new red blood cells into our bloodstream. This is where a concept comes into play: blood doping. Blood doping is something that it's used by a lot of athletes, or was used by a lot of athletes until people started to catch on to it. Blood doping is getting more than the normal amount of red blood cells into circulation, because then it carries more oxygen. You're carrying more oxygen, you're able to do things for longer periods of time. This is why it was seen a lot in endurance events. Endurance events are things that last hours to days. There's a drug, eopetin alpha, and it's a drug that's used to treat anemia. Anemia is somebody who doesn't have enough red blood cells, but it stimulates the production of red blood cells and releasing of those red blood cells out into your bloodstream. It causes, the more red blood cells you have, the thicker your blood is. That is that viscosity. Viscosity is thicker blood. The thicker your blood is, the harder it is to push it through those blood vessels. So that's where it increases that resistance. It's a lot harder for your heart to pump. So people who have too many red blood cells, it's going to give you high blood pressure, because that heart has to work extra hard to push those red blood cells out because your blood is too thick. The more red blood cells you have, the increased risk of stroke. Because again, that blood is too thick. Too much can actually block off a blood vessel and prevent blood from traveling through a blood vessel, hence causing tissues on the other side of that to die off, which is what causes a stroke. Athletes have found a way around these drug tests that are used, because they do a lot of drug tests, random drug tests for blood doping. There's something called natural blood doping now. Go train at altitude. The higher the altitude, the more red blood cells you have, because oxygen is so thin up there, your body tries to pick up as much oxygen as it can, so it releases out more red blood cells into your bloodstream. So a lot of endurance athletes train at high altitudes. There's a very large number in Colorado, Utah, that lives in pretty high altitudes. They train there. They live there. Even in Kenya, athletes that come from Kenya, there's an area in Kenya that has a pretty decent altitude, and all of their athletes train and live at that altitude. So by living and training at that altitude, they have increased their production of red blood cells. And then when they go run races or participate in endurance events, they're usually down closer to ocean level, sea level height, altitudes. So their body has more red blood cells, so they have access to more oxygen, so they're more efficient at their different activities. This is known as natural blood doping. I know a lot of athletes who do that have moved to Colorado to do that specifically. Then they come run races back down at sea level, and they're magnitudes ahead of everybody else because they have more red blood cells. So let's go into white blood cells. As I mentioned, we have 5 different types. Our white blood cells are known as those leukocytes. The main difference between red blood cells and white blood cells still have their nucleus. They're going to have a lot of different organelles in there. White blood cells do not have hemoglobin. Our leukocytes, or white blood cells, are classified into 2 different categories. Granular, or granulocytes, as they're also called, because when they're stained, they have more of these little granules in them. So these neutrophils, all these little dots, are considered those granules. Those eosinophils, especially right through here, you really see all of those little dots. Those are considered granules. These basophils, they've got lots of dots through there. Those are those granules. And then we have agranular, or agranulocytes. That's what they're also known as. They don't have granules like granular white blood cells do. Lymphocytes and monocytes. Yes, for the lab practical for blood, you will need to be able to identify each of these different white blood cells, and we'll go through how each of them are different. So as we mentioned earlier, white blood cells can live for months. They can live for years. They can live for decades. But their main job is to fight off any pathogens that may have gotten into our system. Our white blood cells can do something our red blood cells cannot. And that is, they can leave the bloodstream. That is called emigration, or diapedesis. Diapedesis. They leave the bloodstream to go out into the tissues and fight off different pathogens. Neutrophils and macrophages are the 2 that can do phagocytosis. So they engulf, they eat up any kind of microbe pathogen and kill it inside of them. They do that chemotaxis, which is when they find a bunch of bacteria, viruses, different pathogens that are been released out by these microbes. When these microbes enter our system, they a lot of times release out different chemicals. Without realizing it, these chemicals that they're releasing out attract those white blood cells. So our white blood cells find these chemicals, they leave the bloodstream and they follow the chemicals to follow where these microbes may have gone. When our tissues get inflamed, we have white blood cells that release out different chemicals during inflammation. That also brings some of these white blood cells. So there's a lot of different things that attract these white blood cells. So these white blood cells, they're floating, they're traveling through the bloodstream. They can squeeze through these endothelial cells. These simple squamous cells, they can squeeze right through them and leave that bloodstream. So as I mentioned when we were looking at blood tests, if our white blood cells are high, there's some sort of infection happening or there's some sort of inflammation somewhere in the body. We don't have enough white blood cells. There's a lot of different things that can cause low levels of white blood cells as well. This is where, again, that CBC, that complete blood count, comes into play. We can use those results to help determine if there's any kind of problem or something happening in the system. Neutrophils are the fastest out of the 5 types of white blood cells. They're the fastest to respond to something. They use lysozymes, which is another type of enzyme, to help kill off their bacteria. They also have what are known as defensins. They work like antibiotics because they're going to help us get rid of any bacteria or fungus or fungi that is found in our system. Eosinophils, another type of white blood cell, they release out histaminase, so enzymes. Eosinophils' job is to try to combat the effects of histamine on your system. Those of you who have allergies know what histamine will do to your system. Eosinophils' job is try to fight that so we don't get those effects of histamine. They can also fight against different parasitic worms in our system that may have gotten into our system. They try to fight those off. Basophils, another type of white blood cell here. They release out their granules. They use their granules because their granules have heparin, histamine, and serotonin in them. Anybody who has any kind of hypersensitivity to something, their basophils work really hard. So you're allergic to pollen, dust, pet dander, any of those things, these basophils are working hard when you get those different reactions. Lymphocytes. These lymphocytes are found in our lymphatic tissue, our lymphoplasma, and they're found in our blood. Our lymphocytes are very specific to what they're going to, some of them are very specific. These B cells, they can kill off microbes and they can actually inactivate the toxins that these microbes have released out. Toxins are usually what gives you different types of symptoms when you get sick. We're reacting to those toxins. So B cells can counteract that. T cells, they can attack cells that have been infected by different pathogens, but they can also attack tumor cells. These are the cells for when somebody has an organ transplant. Sometimes, no matter how hard they try to match something, match the person to the organ and everything, sometimes your body will still reject that organ transplant. And that is where your T cells come into play. We also have what are called natural killer cells. These are all different types of lymphocytes. These natural killer cells, I had them explained to me back in school because I still remember it as the front line in the military. They're the first ones out to fight, and they just attack anything and everything that comes across their path. That is what natural killer cells do. Natural killer cells are really good in the back of your throat. When you get a sore throat, that's from these natural killer cells just killing off random cells, trying to get rid of whatever pathogen or microbe has gotten into your system. They're that first line of defense. Monocytes, they are the last type of red or white blood cell. They're the last type because they take the longest to get somewhere. They take longer to reach that site, but when they come in huge numbers. Once they leave the bloodstream, they turn into macrophages. So you had some sort of cut in your skin. These macrophages, monocytes, once they leave the bloodstream, are macrophages. They're going to clean up any debris, any kind of extra damage in the area, any kind of microbes that may have been in the area. Those macrophages engulf. They phagocytize, or phagocytosis, same thing, and get rid of, once they phagocytize, they kill off those different microbes or pathogens that have gotten into our system. So our neutrophils, if we have a bacterial infection, our neutrophils could be high. Had a burn. Even high levels of stress, neutrophils play a role in. Inflammations, radiation exposure, drug toxicity, a vitamin B12 deficiency, lupus, that can indicate low numbers. Lymphocytes, they're high in viral infections. Even some leukemias, our lymphocytes get really high. Mononucleosis, or mono as it's known as, lymphocytes get high in that. If you have a very prolonged illness, HIV infection, if you're taking some sort of immunosuppressant, people who get organ transplants are usually taking some sort of immunosuppressant to try to prevent their immune system from attacking this organ that has just been put into their system. This will cause low counts of lymphocytes. Monocytes. Viral infections or fungal infections are going to get really high. Bone marrow suppression can lower that count. Those eosinophils get high in those allergic reactions. Parasitic infections, even autoimmune disorders, eosinophils get higher. If you're under that constant stress, eosinophils will get lower. An acute allergic reaction, so that's something that comes on really fast. Your body hasn't had a chance to respond to it because it's too quick. So they may have a low count because we don't have enough available to help with whatever kind of reaction. Again, basophils get high in allergic reactions, even hypothyroidism. Pregnancy can cause low counts of basophils. Even during ovulation, basophils go down. Stress, kind of interesting that hypothyroidism, low thyroid numbers, can cause high or low basophils, either or. So let's look at platelets. Platelets come from a cell known as those megakaryocytes. These megakaryocytes are large. They are very large cells. And actually what happens is these megakaryocytes break off little pieces. So this huge cell here is just breaking off piece after piece after piece. All these pieces here, 2,000 to 3,000 fragments, are what make up our platelets. They're just tiny pieces of a cell, so they're not going to have a nucleus to them. Mentioned earlier, platelets are involved in clotting of blood. We have different hormones. Thrombopoietin, hematopoietic stem cells are what differentiate into those platelets. But thrombopoietin is the main hormone that causes more platelets to be created. Platelets only last for days because these megakaryocytes are constantly breaking off more pieces to it. Platelet-rich plasma therapy. As I mentioned, we use centrifuge. Once we've drawn blood, we use a centrifuge to separate that blood. You take the platelets and you can inject it back into a patient to help kind of with tissue regeneration, helping tissues in that area regenerate through using the platelets that were just taken out of the blood. This is something that gets used from time to time to help regenerate tissues in area that otherwise may not regenerate as well. So these are the charts from the textbook that go through each of the different types of blood cells. We have our red blood cells. Females usually have 4.8, males usually have 5.4. Those are just an average. They live for about 120 days and they have that hemoglobin that transports oxygen and carbon dioxide. We have these white blood cells, those neutrophils, eosinophils, those basophils, each of their roles, those lymphocytes and monocytes, what they do in our system, and then those platelets. So I'm sure most of you somewhere, could have been even a TV show, has heard about bone marrow transplants. Bone marrow transplants are used specifically to replace cancerous red bone marrow because red bone marrow can develop cancer. And when red bone marrow develops cancer, it either releases out red blood cells too soon, so they're going to have a nucleus still. It could cause extremely high numbers of white blood cells. There's a lot of different things that it can cause. So they can take bone marrow from a healthy person and transplant it into a cancerous bone marrow. And usually this is done to kind of help get rid of a lot of this cancerous bone marrow. It's usually collected from the iliac crest because there's a lot of red bone marrow in your hip bones and those iliums. There's another way that what can be done. After a baby has been born, there's a way now to freeze and store an umbilical cord because an umbilical cord is going to have stem cells. We can use these stem cells as bone marrow transplants for people with cancer. So it's new, it's stuff that's been out for a while that can be done. It's ways to try to help. Because you can, from an umbilical cord, it can be that same person's. You don't have to try to match up blood type. You don't have to try to match up anything. It's using stem cells from your own umbilical cord, which is kind of cool. So they go into this iliac crest up here, stick a needle in, and they pull out some of this red bone marrow that is making these red blood cells. And then they will inject it into cancerous red bone marrow and try to help get rid of this cancer through this way. Hemostasis. So say you cut yourself. Your body has a step-by-step process to stop that bleeding. That is known as hemostasis. There's different ways. Vascular spasm is one of them. A vascular spasm is when those blood cells eventually constrict, almost close off the blood supply to that blood vessel. When you close off the blood supply to that blood vessel, it's going to reduce the amount of blood that you lose. So this is one way your blood vessels will stop blood loss. We'll look at the platelet plug formation, and then we have a blood clot. So in a platelet plug formation, we get a cut to that blood vessel, tear, whatever. There's endothelial cells that line most of these blood vessels. If those endothelial cells get damaged, those platelets are going to start sticking. They don't stick to the cells if there's nothing wrong. They will only stick if they come across something that is not normally there. So they will stick to that area that was not there. That's where that platelet adhesion starts. Once these platelets get stuck to this area, it causes more platelets to get released. Why? Because these platelets are going to start releasing chemicals. ADP and thromboxane A2 are getting released, which cause more platelets to come to the area. They also help to vasoconstrict, so make those blood vessels smaller. So only small things can get through. And then we formed a platelet plug because that ADP makes more platelets in the area become more sticky. As they get sticky, they stick to each other. And as they start sticking to each other, it brings more platelets to the area, causing them to stick to each other even more. And they're going to block off this area, and they have formed a platelet plug now. That is plugging up that blood vessel. We can also form blood clots. There's two different pathways. There's an intrinsic and an extrinsic pathway. They both form this prothrombinase. This prothrombinase takes prothrombin into the enzyme thrombin. Thrombin takes fibrinogen and converts it to fibrin. And that's all these little threads, these little strings that we see through here. That's that fibrin. These fibrin and these red blood vessels or red blood cells are sticking together to help block or form a clot to plug up that blood vessel. So let's look at these two different intrinsic and extrinsic pathways. The extrinsic pathway is a lot quicker. It happens very fast. We have tissue factors or thromboplastins that are going to leak into the bloodstream. So a blood vessel gets torn. This tissue factor starts to come into wherever this blood vessel was torn. Will come in from the surrounding tissues around it. And that causes that prothrombinase to be formed. The intrinsic pathway takes a lot longer because it's something intrinsic. It happens inside the blood vessel. Extrinsic, that tissue factor is extrinsic. It's outside that blood vessel that comes in. So in this intrinsic pathway, it's going to take time. Because these activators, they have to come in contact with the blood. So we don't need tissues around that blood vessel to be damaged for this to happen. So as I talked about, those endothelial cells that get roughened on the inside of that blood vessel and get damaged. As they get damaged, underneath those endothelial cells is usually collagen. Those long, thick collagen fibers are usually found underneath those endothelial cells. Red blood cells stick to that collagen. And it also causes platelets to come to the area and get damaged as well. So those collagen fibers are going to initiate what is known as clotting factor 12. Clotting factor 12 activates clotting factor 10. Clotting factor 10 combines with factor 5, and that initiates this prothrombinase, and that's what gets this intrinsic pathway moving. So there's a lot more steps to it, and it just involves what's happening inside the blood vessel for something to happen. So these two different pathways. The extrinsic pathway, we get a damage to these tissues. So this tissue factor from outside of the cell goes into the bloodstream, which activates this prothrombinase. This intrinsic factor inside of this blood vessel gets damaged, so we start seeing these collagen fibers. Collagen fibers are going to release clotting factor 12, which activates clotting factor 10, which eventually causes this prothrombinase to form. Prothrombinase eventually turns into this thrombin. Thrombin activates fibrinogen, which activates fibrin, which makes the threads that make up a blood clot. So once this clot is formed, these fibrin tissues or strings, they're going to pull tight. They're going to help to pull together this blood vessel to close everything up. This is known as a clot retraction. So they're holding on to these ends and they're going to pull everything closer together because they're trying to prevent any further kind of damage. We need vitamin K to help form these clots because vitamin K is needed for clotting factors. If we don't have vitamin K to make these clotting factors, this clotting is not going to happen. Our body makes vitamin K through the bacteria in our large intestine again. Now, that bacteria in our large intestine has a lot of different roles, as we will learn in this semester. So these go through the different types of clotting factors, what they are, where they're found. I'm not going to ask you what is clotting factor 1, what is clotting factor 7. I'm not going to ask you that stuff. That's getting way too specific. Just knowing that clotting factors are involved in forming blood clots. Aspirin. People who are older tend to take low doses of aspirin to help prevent strokes because it reduces their risks of those transischemic attacks, strokes, any kind of blood vessel blockage. How it does this is it prevents that vasoconstriction. So when a blood vessel or something gets torn, those blood vessels aren't going to constrict down, they stay their normal size. They also block the formation of platelet plugs because platelet plugs can break loose from those blood vessels. And if they're not broken down, this is what ends up causing those transischemic attacks, those strokes, those myocardial infarctions. We have thrombolytic agents. These are something that gets injected into the system to help dissolve out blood clots. So say somebody has a blood clot kind of floating through their bloodstream. They're going to release out these thrombolytic agents to help break that down to prevent any kind of strokes. Or somebody who may have had a transischemic attack, had a heart attack, they may give these prothrombolytic agents to help break up any kind of clot that is in their system that is blocking off a blood vessel somewhere. So now we're going to go through blood groups and blood types. There's lots of different blood groups and lots of different antigens that are found on our blood. We focus on the main blood groups, the AB, and O. And they are actually done with antigens. Antigens are something that is found on the surface of red blood cells. Some red blood cells have specific antigens, or if you're type O blood, you don't have any antigens. There's also antigens for what is known as Rh factor. That's what gives your blood that positive or that negative. So you're like A positive, A negative, B positive, B negative. That's what gives you that positive or negative on your blood, is having the presence of the Rh antigen on your blood or not. So somebody who is type A positive, they're going to have these A antigens on their red blood cells. They're also going to have that Rh antigen because they're positive for it. Somebody who is A or is A negative only has those A antigens. People who have an A antigen in their blood, they have an anti-B antibody, which means if somebody with type B blood, somebody with A blood gets type B blood, antibodies can come in and attack your blood. So they make sure that you only have the type of blood that matches what's already in your system, these antibodies. Their job is to kill off anything that does not match what should be in your body. So an anti-B antibody will kill off any blood cells that may have a B antigen on them. That is their job. So this is just an interesting chart that they did a different study and looked at different populations or groups and the types of the blood type that is found among these different groups. And it's very interesting to see the most common blood type is usually O. A is usually the second, then B, AB, and then how many have positive? Or is that Rh factor? Just another kind of antigen and antibody that would be in our blood. We're actually going to play with this in lab. We're not going to test our own blood, but we have fake blood that we can play with this with and look at how different blood types, how we blood type people's blood, so we know what we can give somebody if we ever had to do some sort of transfusion. So all of our blood has some sort of antibodies, as I mentioned. These antibodies are going to react with that A or B antigen. So if you have type A blood, you have anti-B antibodies in your blood that will kill off any blood that may have that B antigen on it. Type B blood has anti-A antibodies on it. So if they were to get A blood in their system, these antibodies would attack and kill it off. AB, they have both A and B antigens on their blood cells, so they don't have any antibodies. Somebody who has type O blood, they have no antibodies, or no antigen, sorry. So they have both anti-A and anti-B antibodies. So if they had blood that had type A or type B put into their system, their immune system, these antibodies would kill it off. So this is the interesting one. If we start looking at donors, who can donate blood to who? If you notice, type O blood can donate to everybody because they have no antibodies, or no antigen, sorry, I keep calling them the wrong thing. They have no antigens on their blood. Let's look at donors now. People who cannot donate. We notice here, AB has no donors. Or no, incompatible donors. So type AB can receive all blood types. Type O can donate to all blood types. So that's the interesting part. AB can receive type A blood, type B blood, type AB blood, or type O. Type O blood can donate to everybody. Just some interesting little tidbits here. So we use anti-serum with a glutamate to help blood type. So here's what we would do. We'd take different types of blood and we'd use because there's 4 different blood types, we'd use 4 different little compartments to figure out what type of blood something is. Then we'd drop anti-A serum into the 2, we'd put type A blood here, here, and here. We would put anti-A serum in one, anti-B serum in the other, and we'd look for which one would clot, which is what we're getting here. This is kind of a clot. This is clotting down. So it was treated with anti-A serum. That tells us we have A blood. We took the next type of blood, did the same thing. We treated it with anti-A and anti-B. The anti-B is the one that clotted. So we've got B blood. Do the same thing with the next type. Anti-A, anti-B. Oh, we got both the clot. So we have AB blood. Type O, since they have no antigens, they're not going to respond to anti-A serum or anti-B serum. So this is how we can tell what blood type we have. We'll look at this again before, and we'll do this in lab. We'll get to play with this and try blood typing fake blood. We don't do our own blood because of sanitary and prevention of bloodborne diseases. Not that I'm saying anybody has it, but it's just a health risk that we have to kind of play into. So we will practice this with fake blood, but if you ever work in a lab someday, you'll get to do this with real blood. So when we're donating blood, we need to make sure that donor blood is going to match up to that recipient's blood. If it does not match up, like somebody with type A receiving type B blood, those antibodies, those anti-A or anti-B antibodies are going to go in and kill off any of that donated blood that doesn't match up. That is why we need to make sure somebody with type A blood receives type A or O blood. Somebody with type B blood receives type B or O blood. So there's a lot that we have to pay attention to, and when we're looking at who can donate blood to whom. We have something, this is why the mother, if you've ever had a child or know people who've had a child, they need to know your blood type. Because we have what is known as hemolytic disease of newborn. Hemolytic, heme is blood cells, lytic, lysing, killing them off, breaking them down. Sometimes when somebody who has, now we're looking at the Rh factor specifically. Say mom has Rh positive blood, dad has Rh negative blood. Dad gives the baby Rh negative blood, mom has Rh positive blood. The first child, she will develop antibodies. So, I did that backwards. The Rh positive is in the baby. So dad was Rh positive. He gave that Rh positive blood to the baby. Mom's Rh negative, so she doesn't have any of those antibodies for this Rh factor. But her baby does have this Rh positive. Small amounts of that blood leak out. So mom's going to start developing those antibodies. So if she has another child and the same thing happens, mom's that Rh negative, that baby is Rh positive again. Again, small amounts of that blood are going to leak out. And what's going to happen is there's antibodies are going to go out and attack. They're actually can attack some of those fetal red blood cells, breaking them down. They have shots out now, so if they know about this, especially with the first baby being positive, they're going to give that mom that shot right away when they find out that she's pregnant to prevent the breaking of these red blood cells by the mother's immune system. So she's developing these anti-RH antibodies that'll come in and kill off the baby's blood. So let's look at some of these different diseases that can happen in the blood. Sickle cell disease. It's genetic. It's a form of anemia. Anemia is where we're not carrying enough oxygen. So somebody who has sickle cell disease, they have what is known as hemoglobin S, which is that protein that carries oxygen. The S stands for sickle shape. So what happens if they're not getting enough oxygen into their system? Their red blood cells take on this sickle, this curved kind of shape. Can happen when you go up into high altitudes. It's more common in the African American population, but from what I've heard, they've got different things to treat it. It can be very painful because this shape of this red blood cell can get stuck in the blood vessels. It can block off blood supply, and it can get very painful from what I've been told. Anemia. Again, anemia. They don't have enough oxygen capacity, usually because they don't have enough red blood cells. But it also can be because of not enough hemoglobin. There's lots of different types of anemia. There's iron deficiency anemia, megaloblastic anemia, pernicious anemia, hemorrhagic anemia, hemolytic anemia, aplastic anemia. These all deal with different factors. Some with a deficiency of B12. Red blood cells are too big, red blood cells are too small, not enough iron in the blood. Red blood cells are hemolytic, so they're breaking apart. Hemorrhagic, that's because of a hemorrhage where you've lost too much blood. So there's a lot of different things that can cause it. Hemophilia, it's an inherited. So if your parents have it, one of your parents have it, you may have had it too, gotten it too. You don't have the clotting factors. So your blood doesn't clot. So once you cut yourself, it continues to bleed and continues to bleed because there's no way to stop it. Then we have leukemia. Leukemia is those bone marrow cancers where we get uncontrollable growth of a lot of these white blood cells. So we end up with tens to hundreds of thousands of white blood cells in our bloodstream. We have lymphoblastic leukemia, or acute lymphoblastic leukemia, acute myelogenous leukemia, chronic lymphoblastic anemia, and chronic megalogenous leukemia. These are all different kinds. They just affect different white blood cells. They affect the red bone marrow and how much of specific types of white blood cells that are being made. This is everything on Chapter 19, the blood. Thank you for listening and have a good day.